It's a pleasure to be here. I like to say the oldest person I know intimately. And one of the things that troubles me is that having been there at the beginning of fetal monitoring, I feel somehow responsible for some of the problems that are still with us over 50 years later. Share with you some of the things I'm going to try and cover. I was going to spend a little bit of time on the problems of defining hypoxic ischemic injury using the pH. But I will spend very little time on that. I think that we are here not to prevent asphyxia, we are here to prevent injury. With pH, you have a problem not only with the applicability to the injury, as I'll share with you, but it's something whose trajectory you're not completely familiar with. I would like to share with you, since there's universal agreement that injury occurs as a result of cerebral hypotension or impaired perfusion, that the problem is impaired perfusion or ischemia. And I would like to suggest that there are other mechanisms of ischemia other than those arrived at the end product of severe hypoxia. And part of the solution that I think you are all after has to do with the analysis, a greater analysis of uterine activity. And I want to share with you a dimension for fetal monitoring that has only recently come my way. To help the clinician, I think you who are after the computerization, which I believe must come, will come, and will be of benefit. The fact is it has to answer certain questions. And as basically as I can formulate them, is there anything I have to do for the fetus, for the mother? Anything I have to do about contractions? Is the patient pushing safely and effectively? And I'll deal with that in a minute. What is the feasibility of safe vaginal delivery? All of these are part of the clinical questions that have to be answered. Your objective in achieving those answers is to adopt a philosophy, and that philosophy keeps mother and babies out of harm's way in the first place, and you must avoid, where possible, the need for urgent intervention, whether that intervention is by cesarean section or by operative vaginal delivery. These are very similar data. These are from Scandinavia, from Maria Johnson, and what she did is she divided babies with neonatal encephalopathy according to whether they had a critically low pH or not, and she said those with a low pH were HIE, those above that critical threshold she called no HIE. The problem, of course, is the outcomes were the same. The risk of neurologic findings on MRI are unrelated to the severity of the encephalopathy at birth. I think requiring encephalopathy or severe acidemia at birth as a prerequisite of the events of labor and delivery, as you can see here, narrows the perspective, underestimates the true incidence of perinatal harm, and underestimates the preventability. So what I'm suggesting is that immediate outcomes are nice and helpful, but what you need to do is you need to know more. You need to know about physical handicap. You need to know about mental handicap, including retardation. But you need to understand that some of the effects of the events of labor and delivery are not manifest until you watch executive function in teenagers. I think you also have another responsibility. You need to protect the patient from lawsuits. You need to protect the doctor from lawsuits. And then the last thing, if I have time, you need to protect parents from the allegation of child abuse where the injury occurred during labor. When we think about the impact of brain on clinical asphyxia, it will be critical to keep in mind that asphyxia using pH tells us much about things that can be measured relatively easy, and essentially nothing about blood pressure and perfusion of the brain. I would like to suggest that the use of ECG is to figure out about blood pressure and perfusion of the brain. So I think you want to use the CTG to answer what was just shown in the last presentation about fetal behavior. Fetal behavior is a neurological diagnosis. It's about neurologic function, okay, and the normalcy of that function. It is very, very difficult, okay, to have false positive, normal, reactive pattern. There are no false positives. You can make any baby look bad, but you can't make a bad baby look good. Can't be done. Can't be done. Please, I know you may or may not be using various guidelines for what is excessive uterine activity, but excessive uterine activity is not only more than 4 contractions in 10 minutes, but excessive uterine activity is coupling of contractions, prolonged contractions. There is not a simple measure of uterine activity that is encompassed in a single word, such as tachysystole. I'm going to suggest that there's a way to prevent injury. There's a way to prevent urgency, and we'll get to that in a moment. I've been asked to talk about head compression as a mechanism of injury, okay, a mechanism of injury. The problem about the current approach is that this is in denial of the approach that existed for over a century and a half, that head compression and trauma to the head could be a cause of injury. Okay? The fact is that if a baby is normal on admission, okay, baby is normal on admission, has certain abnormalities of heart rate pattern and MRI evidence of recent ischemic injury, it can't reasonably be explained by severe hypoxia or severe asphyxia during labor. It is nevertheless an intrapartum injury. A word about the dynamics of intracranial pressure. I hope it is obvious that to withstand the pressures of labor for the fetal brain, to withstand the pressures of labor, the pressure inside the fetal head must be greater than the pressure around it. It should be obvious what happens if the pressure around the baby's head is greater than the pressure inside the baby's head. Now that's a problem, because the pressure inside the head keeps the head from being compressed, but the higher the pressure in the head, the greater the resistance to blood flow, which explains why every baby will have a rise in blood pressure during every contraction. I'm going to introduce you very quickly, then pass it on something called the Monroe-Kelly doctrine, which says that blood, brain, and cerebral spinal fluid live in equilibrium, and if one increases, the other has to decrease, or you raise the pressure. It's clear. We know it's true in adults. Whether it's true in the fetus, we think so, but not true. But this will explain, as you will see, this will explain other findings. I'm going to share with you 2 slides. The first set of slides deal with pressure relationships. The second set of slides deal with fetal heart rate pattern relationships. I hope it is clear that when membranes are ruptured and the head is descending through the birth canal, there comes a time when the head is no longer in the uterus. It's not in the uterus anymore, okay? And because it's not in the uterus, it is subjected through these complicated rotations and changes. It is encountering something that reasonably, under the best of circumstances, is a snug fit. And sometimes it's a very snug fit. And what you see here in the lower left is the relationship of uterine blood flow, the pink, the intrauterine pressure, the pressure in the fetal skull, and the blood pressure required. The blue is the blood pressure required to perfuse the brain under that pressure. The difference between the blue and the yellow is called the cerebral perfusion pressure, and it is the failure to maintain that value, perhaps 40, perhaps 50, perhaps 30 millimeters of mercury, that represents inadequate flow to the brain. And the pressure in the brain is governed not all the way around the brain, but at the widest diameter of the fetal brain. And the upper right slide shows you the relationship of pressure at the biparietal diameter as opposed to pressure somewhere else. And you can see that the pressure at the midpoint of the head, the widest part of the head, is the largest pressure being exerted on the fetal head. That pressure can exceed 250 millimeters of mercury. There is no uterus at term that can generate 250 millimeters of mercury. The bottom right is the results of putting a catheter directly into the fetal skull, and you can see the relationship of intrauterine pressure to the intracranial pressure, and under any and all circumstances, the intracranial pressure is higher, must be higher than the intraamniotic pressure. These are two physiologic measurements of the baby. The bottom is the relationship between the pressure on the fetal head and the appearance of deceleration. And you can see after a latent period, there is a linear relationship between the amplitude of the uterine contraction and the appearance of decelerations in the fetal heart rate. I share with you in the upper right an interesting experiment, not done in the fetus, done in, I think, beagles, if I'm not mistaken. And this is the relationship of pH in the brain versus systemic pH in under circumstances of increased intracranial pressure. It should be obvious that the increased intracranial pressure produces a precipitous fall in pH on the surface of the brain, but it does not produce any systemic acidosis. This is the relationship of early decelerations to abnormalities of Doppler flow, and you can see in the presence of absent Doppler flow, or in the presence of early deceleration, in the presence of absent diastolic flow, early decelerations were present in 67% of the babies, and when the diastolic flow was reversed, the presence of decelerations was present in 100%. These are not injured babies, these are not sick babies, they are just showing the temporary effects of head compression, and the term head compression is a misnomer. The term is impaired cerebral circulation. Carl Wood from Australia many years ago did an experiment where he put a blood pressure cuff around fetal heads. 50% heart rate went up, 50% the heart rate went down. All of the experiments trying to show a relationship between head compression and decelerations produce some decelerations. It is not the pressure on the head, it is whether you impact the cerebral circulation or not. That is the test. And while we call it head compression as shorthand, what we are talking about is circulation in the... This is the effect of PO2 on pushing, and what it illustrates is several things. Pushing, as you may know, increases the intrauterine pressure by 50% or more. 63%, I think, is the real average, but it's a big number, okay? And you can often see the transition of the fetal heart rate pattern with the advent of maternal pushing. But unless you get 2.5 minutes of rest between them, for all intents and purposes, the fetus has not recovered from the previous deceleration. And that may be a clue which I will suggest in a moment. I hope that is clear, that pushing changes the dynamics, changes the pressure on the fetal head, requires a certain amount of time for the baby to recover, and you need to take advantage of that rest time between contractions to allow the baby to recover from the previous exposure to that kind of pressure. As the length of the second stage of labor increases, the risk of spontaneous delivery decreases, the risks of operative delivery and urgent intervention increase, the risk of fetal distress and fetal acidosis and then ICU admission go up, and the risk of injury goes up. All of these things increase as part of the second stage, and if you're going to draw your attention to one specific area, that is certainly it. There can be no doubt that the length of second stage, the length of labor, has an impact. And all of these factors are observed in babies. The most obvious of which is that if you take an ultrasound or an MRI of a baby, you will find redistribution of the volume in the lateral ventricles. As part of Monroe-Kelly, the baby has, in fact, to accommodate for the rise in pressure, has redistributed its cerebrospinal fluid. Babies have a 50% likelihood of subdural hemorrhage, of retinal hemorrhage, molding, all of these problems which speak to the forces acting upon the baby's head. There are some wonderful MRIs of mothers in labor, of the babies with the mothers in labor, showing extraordinary amounts of distortion of the skull as part of the, quote, normal labor process. The baby, with all due respect, has known about the problem for 9 months. He knows that at some point he's going to be exposed, or she, going to be exposed to the hypoxemic effects of contractions and the mechanical effects of getting through labor and delivery. And given that amount of time and those developmental resources, he has developed extraordinarily reflexes to deal with them, the most obvious being the Cushing reflex, but the baby has a number of reflexes, dive reflex, trigeminal reflex, that all of which can be used along with various other compensations to deal with the increased pressure. When it can no longer do that, when those defenses have been overcome, then in fact you are subject to injury. The most interesting feature about those reflexes is they are never going to be as active as they were during labor. They will dissipate over the next 6 months or so, change their function because the head is no longer. Okay. For those of you who are used to looking at this, can you tell me when the second stage occurs? Well, if you go to the right end and you see all of the decelerations under the red line on the right, that's where pushing starts. This baby was perfectly normal until the pushing started and the decelerations, and as the pushing kept going and the decelerate contractions were increasingly frequent, the decelerations got worse and worse, and finally you have a prolonged bradycardia. I hope you would know to intervene at C. Maybe I can wish you would intervene at B, but if you were really up to your snuff, you would intervene at A. There are too many damn contractions. That's a risk factor for the second stage of labor. let me assure you that, I hope you will agree that it is fair that this baby has suffering a profound hypoxic ischemic event. I cannot tell whether it is injured. Okay? I am telling you with essential existential certainty that this baby is undergoing a severe hypoxic ischemic stress. Nevertheless, I cannot tell you that I know it is going to be injured. I would have had to wait for the recovery of that bradycardia to be able to. Can I advance the slide? I can't advance the slide. Can you advance the slide? There we go. What I'm about to show you is the pattern of injury. This is a pattern which enables you to make the diagnosis of fetal neurologic injury. It is not the diagnosis of hypoxia. It is not the diagnosis of acidosis. It is a neurologic diagnosis that says, I believe this baby has suffered a neurologic injury. It has the advantage of, not because it's a problem with the heart, it's a problem of the heart rate pattern, and it is mimicked by atropine, and as I said, it is not explained by developing asphyxia. I hope you can see that the initial tracing at the top is quite normal. It immediately goes into this deceleration, bradycardia, that lasts about 2 or 3 minutes. And what I want you to watch is the recovery. Clinically, you would watch, you see there's a tachycardia right above the blue sign, and that tachycardia comes down, but look what happens. And 40 minutes later, the baby has a flat, non-responsive heart rate. It has on the bottom a little variable with overshoot. This baby has been injured. That is what we would call a conversion pattern. It is essentially, in the absence of atropine, the presumptive diagnosis of demonstrable neurologic injury. The risk factors for this pattern, excessive uterine activity, prolonged labor, prolonged pushing, malposition, especially with OP, urgent operative delivery, tends to occur more commonly in prima gravidas with normal labor. And I said, it is frequently preceded by more obvious variable decelerations. But the sudden change in that pattern is what gives you the diagnosis. If you use this prospectively in babies who are injured in association with vacuum, you can see that the majority of those babies demonstrate that pattern prior to the application of the vacuum. They've already been injured by the conduct of the second stage. I don't want to deal about the controversy. There are a lot of people who think that head compression does not exist. It's something us legal experts created, and this information seems to have made no mark. They will accept it under extreme degrees. This graphic is from Chris Lear in New Zealand, and I can get over this controversy very quickly. And I should like to offer you some keys to preventing injury. And one is avoiding excessive contraction. I don't know a greater acquired risk factor than too many contractions. Okay, and it's not just the frequency, it's the pattern, how regular they are, how evenly spaced they are. As Dr. Bacher showed, that the most important feature of contractions is not amplitude, but rest time, the amount of time you have between. I think you need to adopt heuristic pushing. Pushing that is heuristic depends upon what the fetus tells you what to do. So the response of the fetus is used to tell you whether to continue pushing or to stop pushing. And if you want to do this prophylactically and take advantage of the 2.5 minutes, have them push with every other contraction. But if the baby's heart rate has not recovered, you need to use the cessation of pushing as an instrument of fetal resuscitation. How much time do I have? None? 3 minutes? I want to show you a tracing. As I promised, this is a tracing none of you have ever seen. It is the tracing that occurs when a bradycardia, a fetal bradycardia, occurs in a room with nobody in attendance. The bradycardia lasts for 30 minutes, unattended. So what I want to show you is, on the bottom tracing, I'm sorry for the presentation, this is an old slide. On the bottom you can see the heart rate at 60, absolutely flat, rising slowly to the red dashed baseline of about 140. So the heart rate has been down, not returned to the 140 for about 30 minutes, unattended. Heart rate is flat in the upper, it wiggles a little, and then look on the bottom. Do you see the little spikes in the rate? This is at 3 centimeters a minute. That is not normal accelerations. What I believe you are seeing is a baby who is seizing. Okay, so you see all of these and you'll see those spikes get closer and closer together. And here is a pattern that it evolves to. This recurrent spiking pattern, okay? Spiking, some decelerations, but this very high frequency, low amplitude oscillations, which could not be more abnormal. And this pattern continues, moderates a little, moderates some more, and 4 hours later, becomes hard-pressed to tell from normal. Baby is wiped out, severe, massive brain damage, but that's its heart rate pattern. If you had used the last 30 minutes or the last hour, you would know very little about that baby. I want to take advantage and show you one tracing in which a pregnancy at term, slow progress in labor, 6 hours second stage, pushing times 4 hours, vacuum times 2, forceps times 2. The baby is delivered from below. These operations are going on for 25 minutes. APGAR scores of, quote, 8 and 8, unquote, and the baby goes home with the mother, and this is the tracing. And if the arrows are there, you will see the difference in the variability following the deceleration, the difference in the variability with the upper arrow and the lower arrow. So the baby, I believe, has had this conversion pattern. I believe the baby has suffered a acute hypoxic ischemic event. You'll have to read it. It's too difficult. Malcolm Gladwell said the key to good decision making is not knowledge, it is understanding. We are swimming in the former. we are desperately lacking in the latter. We have, as human beings, a storytelling problem. We're a bit too quick to come up with explanations for things we don't really have an explanation for. I call your attention to the horse. Can't see all of it, but I hope you can see which direction it's pointed. Thomas Pynchon stated that if they can get you asking the wrong questions, they don't have to worry about the answers. And I leave you with Agatha Christie. How much do we know at any time? Much more, or so I believe, than we know we know. Thank you.